Level 1, the pre-med. You are 18 years old and you tell people you want to be a surgeon? They nod. They smile. They have no idea what that means. Neither do you. Not yet. You study biology in a fluorescent classroom. You memorize cell cycles, enzyme pathways, the names of bones most people never think about. You do it at midnight, at 5 a.m., between shifts at the campus library. You drink bad coffee. You take practice tests until the words blur. Your roommate goes to parties. You watch lectures on YouTube about surgical anatomy. The MCAT arrives. 4 hours of questions designed to find out if you're serious. You score well. Not perfect. Well enough. You apply to medical school. 14 of them. You get into 2. You pick the better one and move to a new city with 2 suitcases and a number that represents your student debt. You don't say the number out loud. It feels wrong to say it out loud. On the first day, you sit in a lecture hall with 140 other people who also want to be surgeons. By graduation, most of them won't be. You don't think that applies to you. That's the dangerous part. Level 2, the medical student. The first 2 years are a library: anatomy, physiology, pathology, pharmacology, 400 drugs and their mechanisms, 40 syndromes and their presentation. The difference between 1,000 conditions that present identically until they don't. You learn to think in differential. Not what is it, what could it be, and what kills the patient fastest if you're wrong. Then third year arrives and the hospital opens. You put on your short white coat. Short because you haven't earned the long one yet. Everyone knows what the short coat means. Nurses know. Residents know. The attending physicians definitely know. You shadow. You observe. You hold retractors in the operating room for 3 hours while a surgeon repairs a bowel. You don't speak unless spoken to. You don't move unless told to move. You watch. Your hands are in the room, but you are not yet part of the room. One afternoon, an attending hands you forceps during a straightforward skin closure. Close this for me. Your hands shake slightly. You don't let the shake reach the tips. You close it. Not beautifully, but closed is closed. The attending nods once and turns away. You understand something important for the first time. This is not about grades anymore. This is about your hands, your judgment, your ability to function when the room is tense and the patient is open. The library was preparation. This is the real test. Level 3, the intern. Match day arrives. Your name appears next to a hospital. General surgery residency. 5 years minimum, possibly 7. You move again. New city, new apartment. The number representing your debt is larger now. July 1st, the first day of intern year. Every hospital in America fills with new doctors who are legally physicians and operationally terrified. You are one of them. Your pager goes off 40 times before noon. Patient in room 6 has a question. Patient in room 11 needs lab. Patient in room 3's family wants to talk. Patient in room 14 is complaining of chest pain, probably anxiety, but probably needs an EKG. But probably you should go right now just in case. You run. You answer. You document. You draw blood you weren't trained to draw and place IVs in veins that don't cooperate. You make small mistakes. You catch them before they become big ones. Sometimes someone catches them for you. That feels worse. You sleep 4 hours. You come back and do it again. In the operating room, you retract and suture and occasionally hold the camera during laparoscopic cases. The chief resident stands beside you. Not because they trust you yet, because they don't trust you yet. By December, the shaking in your hands is gone. By March, you stop double-checking every order and start trusting the ones you know. By June, you realize something no one told you before intern year. The job isn't medicine. The job is managing chaos while also doing medicine. Level 4, the junior resident, years 2 and 3. You operate more now. Real operations, appendectomies, cholecystectomies, hernia repairs. You are primary surgeon on cases a senior resident supervises. The attending is nearby, sometimes in the room, sometimes down the hall. The knife is in your hand. That changes everything. The first time you hold a scalpel over an abdomen that belongs to a living person, the room is very quiet in your head. Not calm, just focused in a way that feels like quiet. You make the incision. The layers open. Skin, fascia, muscle, peritoneum. Each one behaves differently than the diagram suggested. The tissue is warm and resistant and real in a way no textbook prepared you for. You find the problem. You fix it. You close. The patient wakes up. That moment, the patient waking up, never becomes ordinary. When you decide early that you won't let it become ordinary, but complications arrive, they always arrive. A patient bleeds more than expected. You control it. Another develops a wound infection. You manage it. A bile duct you repaired leaks on post-operative day 3. You're in the room at 2 a.m. reviewing the imaging before calling the attending. You make the call. That's the difference between a junior and someone who wasn't ready. Not whether complications happen, whether you catch them fast enough to fix them. You start to understand your own technical weaknesses, the maneuver that makes your hands hesitate, the tissue plane you lose twice before finding. You drill them in your spare time on simulation trainers and pig models. You become systematic about your own deficiencies. That's when the good surgeons separate from the rest. Level 5, the senior resident. You run the service now. The interns paid you. The juniors bring you their complications. You triage the operating room schedule. You answer the 3 a.m. calls and decide whether the attending needs to come in or whether you have it. Most nights you have it. The operations get larger. Bowel resections, liver cases, trauma. You stand on the primary side of the table for cases that took decades to master, and you do them under supervision that grows lighter month by month. You develop something that doesn't have an official name in the curriculum: surgical instinct. The sense that something isn't right before you can articulate why. The slight change in tissue color, the unexpected resistance, the anatomy that doesn't quite match the imaging. You stop before you cause a problem. That pause, when that half second of clinical suspicion saves your first major complication. An attending reviews the case later. You made the right call, he says. You were 2 millimeters from the hepatic artery. You don't say anything. You go home and sit quietly for a long time. The weight of surgery is not the complexity of the operation. It's the weight of the gap between what you know and what the tissue requires. You carry that weight. You don't let it slow your hands, but you never put it down. Level 6, the fellow. You could have stopped at residency. General surgery is a complete career. Hundreds of surgeons work their entire lives at that level and do it well. You didn't stop. Fellowship, 1 to 3 more years. A subspecialty. You chose one of the harder ones. Cardiothoracic, hepatobiliary, vascular, neurosurgery, which required its own residency entirely. Transplant, oncologic. The names represent the most complex territories the human body contains. You move again. New hospital, new attendings, new hierarchy. You are a resident again in practice, even if your badge says fellow. The operations are longer, 8 hours, 12 hours, sometimes more. You stand in the same position for periods that exceed what the human spine was designed to tolerate. You develop a system, shift your weight, breathe, stay present. The cases are the ones other surgeons refer out. The tumors nobody else will touch. The vascular reconstructions that require millimeter precision over several hours. The transplants that happen at 4 a.m. because organs don't wait for business hours. Your attending operates beside you now, not above you, beside you. That changes the dynamic entirely. You stop being a learner inside someone else's operation. You become a surgeon who is still learning. Those feel like the same thing. They aren't. Level 7, the attending. The letters after your name are complete. You sign your own operative notes. You make your own decisions. The resident stands beside you where you once stood. Your first solo case as a fully licensed, fully credentialed, board-certified attending surgeon. The room is the same. The lights, the table, the smell of cautery, the quiet hum of the anesthesia machine. All of it the same. But you are the most experienced surgeon in the room. That is new. You operate cleanly, efficiently, no wasted motion. You've done this procedure enough times that your hands know where to go before your mind consciously directs them. Muscle memory built across 15 years of training. The case finishes well. You speak to the family in the waiting room. They ask if everything went okay. You say yes. They thank you. You walk back to the locker room. You sit for a moment. 15 years since you told people you wanted to be a surgeon? Since they nodded and smiled and had no idea. Now you understand why they couldn't understand. You build your practice. You take difficult cases other attendings hesitate to accept. You develop a reputation for a specific operation, a specific approach, a specific outcome profile that starts drawing referrals from across the region. Your name starts appearing in places, lectures, journal articles, grand rounds invitations. You become someone other surgeons mention to their patients. That's an entry to the next room. Level 8, the specialist. There is a subset of operations that almost no one does. The cases that get discussed at national conferences. The tumors considered unresectable until someone resected them. The reconstructions that require 2 surgical teams and 14 hours and a level of anatomical knowledge that exceeds what most training programs cover. You become one of the surgeons who does those cases. Referrals arrive from other states, from other countries. Patients who were told no everywhere else. Families who found your name through a paper you published 2 years ago. You operate with teams now. Plastic surgery, urology, interventional radiology, cases that require coordination across specialties, across departments, across institutions. Before every major case, you spend time alone with the imaging. May you walk through the anatomy in your mind, the vessels, the planes, the likely variations, the contingencies if the tumor is more adherent than expected. You plan the case 3 times before you scrub in. Something shifts at this level. The surgery itself becomes less frightening and more demanding. You are not afraid of the operation. You are deeply respectful of it. Fear makes hands shake. Respect makes hands precise. You teach more now. Residents rotate through your service. Fellows come specifically to learn your techniques. You find yourself using words you heard your own attendings use 20 years ago. You understand those words differently now than you did then. Level 9, the complication. Every surgeon at this level carries one. Not because they were careless, not because they were incompetent, because surgery is performed on living bodies with vascular anatomy that varies, tumors that don't respect boundaries, and physiology that changes faster than imaging can capture. Yours arrives on a Tuesday, a case you've done dozens of times, a patient you prepared for carefully, an intraoperative finding that required a decision with no good options, only less bad ones. You make the best call available. The patient does not recover well. The review process is formal and structured. Your colleagues examine the operative note, the imaging, the decision timeline. They find no deviation from standard of care. You made the right call. The patient still didn't make it. That distinction, the right call and the wrong outcome, is something no one outside surgery fully comprehends. You go back into the operating room 5 days later. This is what separates surgeons from people who tried to be surgeons. Not the absence of bad outcomes, the ability to continue after one, to carry it with appropriate weight without collapsing under it, to learn everything there is to learn from what happened and apply it to the next patient who needs you. You carry it. You don't put it down. You operate the next morning. Level 10, the institution. You've been doing this for 30 years. Your hands are still steady. You've maintained that with discipline, deliberate practice, years of protecting the fine motor function that everything depends on. You don't take the most complex cases anymore. Not all of them. You select the ones where your specific experience provides something irreplaceable, the ones your fellows aren't ready for yet. You've trained dozens of surgeons. Some of them are now attending surgeons in major hospitals. Some have developed techniques of their own. One of them trained someone who saved a life last week in a city you've never visited. You sit on committees. You review programs. You write guidelines used by surgeons who graduated the year you started residency. The operating room still does something to you. The lights, the table, the smell, the silence before the first incision. It still matters. You decided long ago you wouldn't let it stop mattering. A medical student rotates through your service this month. 18 hours in, slightly overwhelmed, asking questions that reveal how much they don't know yet. You or them. They ask you what the hardest part of becoming a surgeon is. You think about it seriously. The hours, you say, but not in the way they're thinking, not the length of them. It's learning how to be fully present inside every one of them. They nod. They don't understand yet. They will. Somewhere right now, someone is telling their family they want to be a surgeon. The family smiles. They have no idea what that means. And neither yet does the person saying it. The operating room is waiting. The cycle begins.